in which case, Kathy, we will go on to you. Update on actions taken in response to Dr Kirkup's review into Liverpool Community Health.
Thank you, Chair. So the board will remember, of course, that in March, Ian reported on the Dr Kirkup's review and committed to implementing the recommendations and updated at the May board about where we'd got to. So this is a further update to show the progress that we're making. We've pulled them out into sort of 5 key areas where we're working, obviously around the trust appointments and talent management. And some of that, whilst it's progressing, will be enhanced by having a chief people officer, has already been referenced. So I think that's an important factor. And then there's quite a bit, I'm not going to go through all of these things, but there's quite a bit on assessing the risk in trusts in order that we don't have similar things happening in the past, and in particular around community trusts, which sometimes can get a little bit overlooked because we don't have the same measures always. And regions have conducted an early rapid review, and I think it's fair to say that we've got further things that we will be going on to do. So there'll be some scenario testing which will be done in the autumn, and also to note, as it says in the actions, that Ruth and myself have now completed our review of all the 5 regions in terms of going through every single organisation, looking in particular at the softer things, the whistleblowing, the staff survey, the GMC survey, all the things that might give you an early indication of issues. So we will report on that at the September board more formally, as we committed to have completed that by the middle of July, which we have done. And I think it is fair, early reflections is it was a really valuable thing to do, but you'll hear more about that in September.
When you bring it back in September, it would be fantastic to hear your reflections on how we might change ongoing processes.
Yes,
so that it's not a one-off.
Absolutely.
Absolutely. I think the freedom to speak up element in particular was a new lens of looking through it, and it showed the value of that whole process.
So within the commercial world, as others will know, that we would pull together whistleblowing, grievances, staff surveys, complaints, all of those into an integrated dashboard, which would be a regular part of our quality and ongoing assessment.
Yes. And I think this is I think you're absolutely right, and I think this, our sense was, because we've only just completed all 5, so Ruth and I need to do a bit more reflections together, I think, before we bring it back to the board in September. But it's exactly those sort of things. I think we found it really valuable as a different lens, getting people to think about it in a little bit of a different way rather than some of the usual things. But you will see where that is all up to. And then there's obviously various other things that are ongoing in terms of review of the services themselves, and there's plans for that with Mersey Care and so on. So I won't go through them each one, but if anybody's got anything you would want to raise, very happy to take that. The only other thing is there was an action around that the Minister had raised about whether or not the appointments and movement of people had been appropriate, and a review was commissioned and is appended here for board members to see and reflect on as well. So I think I'll pause there, but obviously take any queries or questions.
Sarah?
It's a small point, but it came out of a meeting I was at with the chairs from one of the regions yesterday. We talk about the quality impact assessments we do on cost improvement programmes. And the chairs pointed out that there, as far as I understand it, there is no matching quality impact assessment done by CCGs when they institute QIPs. Now, that was said to me yesterday and all the chairs nodded. Now that's obviously it's not for this board,
No,
but
we'll take that away.
Yes.
Yes, I'm not. Yeah, I couldn't say yes or no because we don't, directly deal with that. But I would say one would assume they
I
would,
would have thought that
but
they
whether
did.
they do or not,
Yes.
we'll take that away.
If you could, I think it'd be interesting.
Yeah, I mean, just in terms of quality impact assessments, which was a really important thing, as you'll note from the report, we held with Ian some star chambers, as we call them,
Mhm.
where the regions presented their most challenged
Mm.
organisations, and we had, fairly in-depth discussions with Ruth and myself being there for one or other of us, at least for those. But I think that we have continued to look with trust across the piece, the medical and nurse directors. What's their process for doing this?
Yes.
And it has to be said, some could improve the robustness of that and also how they track through the year. So it's very much in our minds to keep a close eye on.
Just a couple of points, and the first was the issue about the risk factors that David mentioned, and it's about whether we've got a common view with CQC around this, because most of those things were built, I think, in the past into the sort of risk assessment work the CQC did around organisations, things like the staff surveys, complaints and all of this. And it's really just whether we've got to a consistent position between us and CQC, so we're looking at the same things and taking the same view of risk around this type of issues. That was my first question. The second question was something entirely different, and it was sort of relating to the independent report around the decisions that were made and whether there are any new lessons from that into how we deal with this type of issue in the future. Because I know in response to the report last time we discussed what are we going to do about how we move people about, and it's really, does that independent review give us any new insights about things, or is it confirmatory?
Shall I suggest I answer the first one and then, I don't know, Ian might want to
Yeah.
answer the second.
Fine.
So on the CQC, and have we got a similar view of risk?
Yeah.
I mean, I think it's a really good question, and I have just come from it's made reference to in the paper, the Joint Strategic Oversight Group, where the CQC, HE, the GMC, NHS England and ourselves were today, and we have been through, the whole country, focusing on the challenged and special measures end, but also looking for where have we got the ones that are emerging. I still think we've got more work to refine this, because I'm not sure we're all looking at exactly the same information all of the time, and I think that, and how we interpret it, may be just slightly different. And I still think we've got some lessons to learn so that people don't get caught out, because, for example, the CQC go in and find things that others hadn't expected. I think we're still in the, I think we've got past base camp, but I think we're nowhere near the top of the mountain on this one. I think we've got quite a long way to go. But we are at least sitting around the table talking about it and thoroughly going through things, which is progress, I think, and also having that done at a regional level as well, which when we get to 7 regions, it will be at 7th, not 5th, which it is at the moment.
Perhaps I could just pick up on the second of your points, Richard, which I think the Newton report at the end is sort of sending us a message that we are on the right tracks. I think I would summarise our position as we need to be able to have a different deal with our leaders, taking on running organisations that supports people in doing the difficult jobs that they have, and at the same time supports people develop their careers and help them build their careers in a way which helps the NHS. When things don't go well, we also, I think, have confirmation here that we should address that situation. We shouldn't move people who are unsuited into other jobs that they would be unsuitable to do. But at the same time, we need to be able to distinguish between people who are unsuitable and people who are potentially suitable in a different job, haven't crossed moral lines such that there's talent there that can be saved and supported for the NHS. And I think if you think about the work we're talking about in terms of talent management, leadership development, supporting our leaders in difficult jobs, I think this report goes some way into emphasising why that's important, and why when we have the Chief People Officer joining our team here on behalf of NHS England and NHS Improvement, they'll be able to oversee that sort of a system. And I think that potentially is a better way of dealing with people, both in good times and in bad times.
So fundamentally, the report concludes that we do need to shift custom and practice in the system, don't we? In the way that we manage senior leaders' development and performance.
Absolutely.
So it is, to your point, Richard,
Confirmed.
confirmation.
It is
that
confirmatory.
confirmation in the
It's
sense that change
No.
is necessary,
Okay.
and reaffirms that we have to take the actions that we've set out.
Absolutely.
Kathy, I had a question for you, if I may, as Chair, on the stress testing that we haven't yet started. Listening to the debate just now, it struck me that we ought to be thinking about how we specify that stress testing to look at all angles. So we're looking at the people lens that David just set out, just as much as we're looking at the financial lens, but also that we design the stress test with our other industry partners, system partners. And I wonder whether, if we haven't started that work, whether we could bring back electronically to the board what the brief will be. Because it seems to me that's actually a very important step
Okay.
in getting a real assessment of whether or not we would make, as a system, the same mistakes again.
Yes, I mean, I think that seems eminently sensible. I think one of the reasons is probably it hasn't started is actually trying to think through exactly how to do that most effectively. To be honest, and so I think we can well do that, and I think we will learn from what Ruth and I have done and comments that David's made, for example, and bring that together. But I think looking at scenarios is one of the things around the stress testing, is taking a scenario and saying, if you applied these things to it, could you have picked this up earlier? Which is a little bit of the sort of thing I was doing this morning and so on. It's an incredibly complex thing to do, but I think if we get the things that you need to look at and take the focus a little bit more into what I would call the canaries in the coal mine, the things that actually sort of come up. And when you look back, frankly, at some of the organisations where we've had trouble, when you look back, you do see somebody will say, well, we did have trainees that were in difficulty, or there was a staff survey that showed they were poor, and you could have seen it earlier if it's how you get the noise out of the system that actually says these are the important things.
That's why I'm thinking there might be some value in just a sort of progress check-in on that piece of work to force us to crystallise what is it that we're going to do that's going to help us learn.
Let's do that.
Let's do it.
So,
And we have had another trust go into quality special measures in the last month, and it wasn't a name that I expected to see.
No.
So, yet again, it looks like we were perhaps taken by surprise.
And I think there's also, I think that's recognised, and one of the things that we're talking about, and certainly one of the organisations in another part of the country which hasn't gone into special measures but is awful close, that particular region is doing a review of what do we learn from the why have we got so close to that without any prior real knowledge. Certainly it hadn't been an escalated thing. So I think we're very conscious of it. I think there's something about the bandwidth of people to do some of this just this minute, and I think we need to recognise and see if we can streamline that to make it as easy as possible.
yeah, agreed.
Tyler, can I just come back? I think two observations. One is we're right to apply our lens from our regions and our national teams, but we mustn't. We need sorry, to put it in the positive. We absolutely also need to re-emphasise and retool boards to be able to spot their own problems.
Absolutely.
And I think that's the
first
because
line of
actually
defence.
it is
Exactly
absolutely.
right.
And the thing that I come back to on that is that there is no, for all the measures and metrics in the world, there's no substitute for walking around and talking to people. And therefore I think the extent to which we are encouraging boards, supporting boards, enabling them to look not just at the data but also to seek out the qualitative stuff, I think is really important. And then the second thing is and this links in totally to how we respond and the behaviour of our response at a regional and national level, and dare I say a ministerial level, sets the tone as to whether people are willing to open up. Because actually the best thing we can do is create a culture where, I think this is the most important thing actually, create a culture where people feel, when they start to get that little nervousness in their stomach that says something doesn't feel right, that actually it's a sign of enormous strength to ask for help, not to and to escalate and to seek support, not to say, I better try and fix this.
Yeah.
And I think that boundary between accountability and asking for help is really important. But we do need to think equally about how we respond and how the system responds, rather than just dumping on people and therefore causing them to not ask for help when things can get solved and when it gets out of control. Because these things usually, my experience, it's a spiral. They start small, they just get a little bit bigger, and then suddenly they go out of control. And stopping them early, I think, is not just spotting them, but helping people to stop them is key to us in this.
And that's one of the reasons we have what we call our challenge provider group, is that we actually provide them active resource, people to support them.
Yeah, forgive
and
me for
the
my
aim,
lack of knowledge.
No, and to actually stop that, and we have got a recent example of where we've actually done that, and Portsmouth would be a very good example of where we were very afeared that they might go into special measures. We changed the leadership, gave them a lot of support on the ground, and they have improved, and that's a really good example, and there's plenty of that. So yes, it is around, absolutely agree, and we know for a start that for absolute fact that if an organisation seems to be going off, or indeed goes into special measures or whatever, if they are in denial, if they're trying to push it away, we know that that's a very bad sign as a board in terms of their recovery. So,
and the only comment I'd say, and I apologise for picking up, but your comment there was we changed at Portsmouth, we changed the leadership. I'd love to be able to do it without changing the leadership. Now, I'm not talking about that circumstance, just generally.
yeah.
Aaron.
Chair, I think the CQC has been around for how long now?
6 years, is it?
6, 7 years, yeah. Considering that they regulate many of the providers, I think it's about time to start thinking in terms of the tools and the metrics they're using and the validity of these. You know, we're all living in what we all describe as a learning health systems. I think we've just talked about early detection, prevention, but I think it's also worthwhile to see how could the whole system learn from this rather than through us, per se. So I think there's 2 components to be done. One is the validity of the metrics and the tools that we're currently using. I know CQC's regulatory firm is slightly changing from 24 people landing for an inspection to more what we call an intelligent regulation based on data and analytics. And I think at the same time regulation is one thing, but it's also an amazing tool for learning. And how could we find ways in which the whole system learns from what is happening across the NHS being a single system for the future. It's a piece of work to look at, or at least commission within through the board.
I think in different ways, a number of us are saying something quite similar, which is this action in the update where we will work with other national organisations to conduct exercises that stress test our current oversight approach against a range of scenarios and use the findings of these exercises to improve our approach to assessing risk. I think that's the right action. I think it would be helpful for the board to see some of the work that's going on towards delivering that action rather than waiting for a sort of perfect resolution. I think we're all recognising that this is really important and really complex and requires proper thought. Okay. Any other comments on Cathy's paper? And there are quite a lot of actions that are due for September.
There are, yes.
So I'd be expecting a more meaty set of progress around particularly some of the sort of the leadership elements that we need to have made progress on for the next board meeting.
We'll make sure that is the case.
Okay.